So it's great to be here, and I'm kind of a wanderer, so if at times I wander in front of the screen, I'll try and get out of the way right away so you can get the information that's on there. Mike Busdicker, I'm the Senior Director of Clinical and currently the Senior Director of Clinical Engineering at Intermountain Health, based out of Salt Lake City, Utah. I'll cover a little bit more on that. I've realized at the last MD Expo that was in Connecticut that when they put my name up there in a presentation and stuff, they also included Piper. Now, Piper is my service dog. She's over there against the wall. We've been together for 2.5 years, and everybody's more interested. I think if she could do the presentation, she would do the presentation. But anyways, Piper is 4.5 years old. She's a Labradoodle, and I get a lot of people that look at her and they go, Labradoodle? How's that? Well, so I would put another picture up there. That's her brother, her full brother. There were 8 puppies in the litter, and she got most of the lab, which I'm okay with. I'm okay with. Anyways, what we're going to talk about, we'll talk a little bit about Introduction to Intermountain Health, so you'll see what type of a program we've got and what the organization is all about. We'll talk about some of the baseline program elements for HTM or CE. Understanding a dashboard. What is a dashboard? I've got some examples of some of the dashboards that we track and that we look at. Understanding huddles. What is a huddle? And what are huddle board examples and what can they do for you? And then using those together, the dashboard and the huddle, kind of combining that and how that drives performance. I'll talk a little bit about continuous improvement and then leave some time for questions as well. So intro to Intermountain Health. We were just mainly contained to the state of Utah, but a merger with Sisters of Charity Leavenworth 3 years ago that brought us up to 33 hospitals, 400 clinics, 6 primary states, Utah, Nevada, Idaho, Colorado, Montana, and Wyoming. The hospitals are actually located in Colorado, Utah, Idaho, and Montana. We have 1 hospital in Idaho, and actually our newest Intermountain employee right here, Justin, just joined, will start at Intermountain on Monday at our hospital in Burley, Idaho, at Kaja Hospital in Burley. Select Health, we have our own health program, so we are an IDN, 1.1 million members and growing. We've got our total revenue for the organization's over $16 billion, 4,800 licensed beds. We have in the HTM or CE program, we have 179 FTEs. Now, not all of them are techs. Some of them are support personnel. So I've got regional or area directors. We've got some managers. I've got a service dispatch center, parts and inventory coordinator, service contract management. So we've got some support personnel in there as well. We have over 200,000 assets in the inventory. And that fluctuates based upon, in fact, there's a meeting that's going to happen in May. We're going to talk about inventory because the Joint Commission says you'll inventory all medical equipment, and that's left up to interpretation, I believe, by Joint Commission surveyors, because I've had surveyors come in and say, is that blood pressure cuff inventoried? And I said, it's $75 new, and it's a manual BP cuff, and no, it's not on the inventory. So I've had some surveyors look at it and say it should be, some that say don't. So we're going to take a look at that. We also own our own life flight functions, and we just bought, well, I just say just bought, a few years ago, we bought Classic Air. So we have 20+ air bases throughout the country, including Alaska and Puerto Rico. And I've had technicians that have volunteered to go inventory that equipment in Alaska and Puerto Rico, but we said, no, that's okay. So we've got a depot service that's set up that they send that equipment in, and we've got loaners that we send back out. And I've got techs that specialize in the equipment on the life flight helicopters. And actually, Intermountain is the only healthcare organization in the country that has clinical personnel that are certified for lift extraction in the mountains. And the helicopters are pretty special. I asked one of my techs once, I said, hey, can you give me a ride in that helicopter? And he said, yeah, sure. You see that mountain over there? Yep. He said, climb up it and jump off, and they'll come get you. No thanks. So baseline program requirements and objectives for an HTM program. And I know a lot of you know this. You know, the most important thing, and I think from an industry perspective, when we look at HTM, when we look at clinical engineering, sometimes we lose focus on what's important. And to me, the most important thing in that is patient safety, and it's our patient. Because our patient is the one that really, the things that we do allow our clinicians to take care of those patients and treat those patients. So patient safety and our consumers, our patients, are the most important thing. And we need to keep that in mind and remember that. Regulations, whether you're accredited through DNV, Joint Commission, and you know, when we look at the regulations piece, there's multiple. You've got to look at that federal standard. A lot of people look at it and go, well, the FDA runs us. Well, no, they don't. CMS does. CMS is the ones that put together conditions of participation that we need to meet in order for the hospital to be reimbursed. So CMS is the one that sets those guidelines for us, or sets those standards for us. And then our accrediting organizations like Joint Commission or DNV are the ones that come in and enforce that and survey and accredit the organizations. Now, I've heard from Herman McKenzie that going forward, Joint Commission is going to do some refocusing, and CMS is along with that, and they're going to start accompanying some surveyors on surveys. So CMS, you don't be surprised if your Joint Commission doesn't show up and they got a CMS person with a CMS. I don't know why we got CMMS with our computerized maintenance management system, but yet Center for Medicare and Medicaid Services drops one M. So they're just CMS. Standards. Does everybody know that the state that you work in, the state health department, they can set standards and regulations that supersede CMS? So you need to look, what are those standards? One of the things that we found out in Utah, we started looking at hospital beds and we said, do we put them on an AEM program? And we started looking at it, and the state of Utah said, no, you'll do PMs on those once a year. That's a state requirement, and there's no way around it. So you need to look at those state health department requirements, as well as they require boiler certification exams on tabletop sterilizers once a year. We've got to have an engineer come in from the state and look at that tabletop sterilizer and say, yep, it's safe to use. And not all states have that. So you got to look at the standards and those regulations from a state perspective as well. Stewardship, being fiscally responsible. We've got to be fiscally responsible for our patients, for our organizations. We need to try or attempt to do things at the lowest cost possible, but still maintain high quality and patient safety. Because if we don't, and those costs go up, where do they go? Right back to the patient. How many of you are with organizations that every year your healthcare benefits go up? The cost of them. And it's because we've got to fund what's going on within the healthcare institutions. So we've got to be fiscally responsible from that aspect. Goal alignment. When I look at goal alignment, that means the organization, the board of directors puts together goals, and then our goals, as they cascade down, need to align with the organizations. They don't need to be identical, but they need to align. I always ask people, I say, how many of you have, with in-house programs, how many of you have a mission statement, a clinical engineering or an HTM mission statement hanging on the wall in the shop? And most people raise their hands, and I say, is it the same as the hospitals? And they say, well, no, it's for clinical engineering. And I tell them, take it off the wall, take it out of the frame, tear it up and throw it away. Because your mission statement in clinical engineering or HTM should be no different than what the hospitals is. Your vision and values can be different. They should align with the organization's, but your mission statement should be no different. And it's up to leaders within the departments to help their technicians and their personnel to understand how they contribute to that. Every presentation I do, every town hall I do with my staff, the very last slide on there is mission statement, vision, values, and I relate back to them. This is how we support the organization's mission, vision, and values. This is how we contribute. You know, Intermountain's is we help people live the healthiest lives possible. So my staff looks at it and goes, well, how do I do that? I don't take care of patients. I don't work on patients. Yeah, but you know what? You work on the equipment that takes care of the patients, and they can't live the healthiest lives possible without that technology. Engagement, and that's right along the same lines, ensuring that our caregivers are engaged in the process. Some of the best ideas that we get, and we require our technicians to submit 1 or 2 ideas per year. Some of the best ideas come from the front line. How, and we keep track of that on our Huddle board. I'll show you that in a little bit, but we keep track of that on our Huddle boards with the ideas that come in on those that we can accomplish, those that may take, you know, dollars outside of the organization that we don't have, that we can't contribute or get. And then we keep track of those that are in flight and those that are that we can cascade through the entire enterprise across all 33 hospitals. So ensuring that our caregivers are engaged and they understand the work they do and how it contributes. Improvement, continuous improvement. Really, we look at, and I'll show you some examples here on some of the things we do with continuous improvement around standardizations and things like that. But we're always looking, because we can always improve. We can always improve on workflows, processes, caregiver engagement. We can always improve on those things. And again, some of those ideas are generated. Now we tell the staff, when you generate an idea, and we're not asking you to say, well, if you move the garbage can from that corner to that corner, it creates less steps, which means I don't have as much time to throw stuff, you know, it takes me less time to throw stuff away. That's not what we're looking for. And then satisfaction, ensuring that our caregivers are satisfied with the job, that we're supporting them in what they do, and that they understand that we're committed to helping them grow. We have a competency assessment, automated process that we go through that the technicians self-evaluate. We tell them this is not related to performance. This is not a disciplinary tool. All it is, as a tech 1, 2, or 3, here are the knowledge level expectations on a scale of 1 to 5, 1 being, yeah, I know what it is, but that's it. And 5 being that I could tear it all the way down to the frame, put it all back together, and I can train people on it. So we set the skill knowledge expectation in certain, in general modalities. Sometimes we get specific on the equipment, but we have them self-evaluate, and then we identify the gaps, and we take 1 or 2 of those gaps, put them into an individual development plan, and help them close that gap. And what I tell them is that is our commitment to help you develop, because it's written down. It's in Workday, it's in your HR record. That is our commitment to help you develop. It is not a performance evaluation piece, and it is not tied to disciplinary. The only thing I can say is that if you rate yourself a 5, then you better be able to perform at a 5. And that's why it's important to be really honest on that evaluation. So these things that are outlined on the outside are really what help drive the connected items to HTM. So when you look at inventory best practices, user training, incident response, policies and procedures, any of that, these items tie into those which really drive the HTM department and give you the opportunity to contribute to the organization. So with that, understanding dashboards. So as I was putting this together and looking at it, I thought, do I cover dashboards first or do I cover huddles first? And I'll tell you, they both intertwine, but there's some significant differences between them. They may have the same information, but there's some significant differences. So they really, a dashboard really provides a visual picture of your key metrics, data, performance indicators, and that could be for your technicians, teams, leadership, regulatory standards, anything along those lines. So it really centralizes the data in one place. Now we break that down. I've got it. My dashboard covers the entire system. So I see everything from a system level. Now I can drill into it, but my area directors, their dashboards include the facilities that they're responsible for. And then the managers, their dashboard may be the hospital that they're responsible for. So that information cascades down as well. So it allows monitoring of current and real-time data. So we use our data analytics personnel to help build links so that data automatically updates. So when they go into that dashboard on what we call our continuous improvement portal, when they go into that dashboard, that data is current because it automatically updates, whether it's through Tableau reports or if they're tying it straight to the CMMS. If you can do that, if you've got a CMMS that allows you to do that, which Intermountain is, we're transitioning away from PeopleSoft maintenance management, and we're going to implement EQ2 across the system. Really provides vision and awareness for decision making, so you can take a look at the dashboard data and information and say, we need to focus here, we need to focus there. Why is this low? What can we do to correct that? What are our return to green plans on those? And then really the important parts of the dashboard, key performance indicators, visual data for review. A lot of people, I know from my perspective, when I look at the dashboard, I don't like to look at a spreadsheet of 50 items with a ton of information. Give me a chart or a graph that I can look at that says we're performing where we need to be or we're not. And if we're not, then I can drill into it if I want. And I think you find that the majority of hospital leadership is the same way. They would rather look at the overall because they're not going to dig into the information. They just want to see what's important to them. Customization filters so that you can go in and say, well, I like with me from a system perspective, I may want to look at one hospital, so I can go in and I can select a filter and say, just give me the data for this hospital because that's what I want to look at. And then again, automated updates to the data, making sure as much as you can. Now there are some things that we got to do manual entry, but as much as you can, get that data to feed into the system and update automatically. So you can see this is some of the dashboard information that we track. We look at caregiver documented time. So this is looking at by month, and these are the colors here. These are facilities. So some of our hospitals, and we set our entry at 80% and our target at 85 and stretch at 90. Now I've had techs that come back and say, that's big brother, you want to know what I'm doing all the time. And I say, no, I don't. It's not that I want to know what you're doing all the time. You expect to be paid 100% for your time. I'm asking you to document 85 of that. And actually the number, that percentage, is worthless to me. Provides no good data and information. All it tells me is that they're meeting that standard. It's the data and information behind it. And that's what I have to explain to the technicians is here's the why. Because I can look at that data and say, I've got CE Tech 1s that are spending 50% of their time in admin in this facility, and in this one, they're spending 10%. Why? What's the difference? Where's the disconnect? What can we implement as a best practice to change that? So it's the data and information behind it that really helps. Average age of open work orders, pretty self-explanatory. PM completion by hospital. So you can see that we look at when was, how many of the PMs were due, what was completed, what's incomplete, what are could not locates, and were they late or early, and then what is the percentage of those. Now these are PMs that are managed, so if they're could not locate, they're complete because they're managed. And because Joint Commission requires 100%. And then we can also drill it down to our caregivers. Now, I will tell you that we track it by week. We look at it at a caregiver and we say, okay, you have 100, say you have 100 work orders, PM work orders due in the month. We expect you to be at 25% complete at the end of the first week, 50% at week 2, 75% at week 3, 100% at week 4. Because if you're at 5%, 5%, 5%, now all of a sudden you've got 95% of your work orders are due in the 4th week. And when we track our could not locates, we actually track them by week as well. If we see that a technician is loading up on could not locate work orders at the end of the month, that means they're behind. And they're just documenting them that way. They should not be documenting could not locates in the 1st week, 2nd week. They can in the 3rd, but those first 2 weeks shouldn't be any because they still got 2 weeks to look for them yet. And get assistance from staff as well. Continuous improvement. This is what I was talking about with the could not locates. So if you look here, we've got our target at 1.8% of our PM work orders. That's what we're targeting. Now we were running when I first started at Intermountain. You can see here we're up at 1.4, but we were running at about 7%, 7 to 8% when I first started there. Yeah, and when I started looking at that, I said that's a problem. Now we divide that out and we look at low risk, medium risk, and high risk, because if we've got high risk equipment that's on a could not locate status, that's an issue. Why is it high risk? It may contain PHI. And if it's missing, problem for the organization. We need to find out why. Yeah, go ahead.
When you saw that, was that a culture shift that you had to?
Yes.
How did you do that?
It was through data, performance dashboards and Huddles is how we really impacted that, because that data was then being shared with the technicians and we explained the why behind it. And that's where, you know, from a cultural standpoint, they would, again, we were tracking it, the could not locates, and the majority of them were coming in weeks 3 and weeks 4. And we started digging into that and saying, why is that the case? And it's because they were rushing to get those PMs done at the end of the month. And if they couldn't get it done, they just listed it as could not locate. So we started looking at that data and information, tracking it from week 1 all the way through, presenting that data through a dashboard, as well as, and you'll see on our Huddles, we actually have Huddle boards in our shops that give you a quick snapshot of where the department's at, and it's broken down by technician. And you know what? A little bit of competition is good. You got technicians that look at it and go, man, I don't want to be in the red down here. I don't want to be in the red. Yellow, I'm okay. Green, that's where I want to be. And when they start looking at it, and it also helps teamwork, because we've got techs that look at it and they say, hey, you're in the red on your PMs. You still got more to do. I'm ahead. Can I help you? Or you got technicians who go out and say, I need some help. Or facilities. We have facilities that say, hey, listen, we've got anesthesia machines due, and there's no way I'm going to be able to get to all of them myself. So they'll send out a message, and somebody from one of our other facilities will say, hey, I'm trained in that. I can help because I'm ahead, and they'll go up, or they'll go to that site and help out with those PMs. So that information really drives teamwork, performance, competition, as well as performance improvement. So you focus on those areas when you look at it and say, we're at 7%. Well, where do we want to be? We want to be less than 2%. Entry is 2, our stretch is 1.5. And you can see how we drove performance through these metrics. By hospital, by caregiver. Did that answer your question? Was that okay? Oh yeah.
I was just going to make a comment when I require my teams that if we are going to could not locate a device, that they have to follow up with what we call the UTL letter to the department leadership. And then I say, let them do the work, let them start, then we document if they don't respond to us. But generally, we've had good luck with them.
Yep. And we do the same, especially when we involve finance in this. Because if we started involving finance and sending the could not locate report to them, and they looked at it and said, wait a minute, I'm missing 10 devices, and in order to replace them, I need $100,000. They got involved and started talking to leadership or department leaders and managers and said, you need to help find this equipment. And we had one of them, we had a physician at Primary Children's Hospital, and it was a thermometer, and then we tracked those. It was, I don't remember what brand, anyways, it's one of them that you got to do a PM on every year, and if it's not in its cradle, and charges, and it alarms. And we had a physician that had one that he specifically liked, and he put it in his coat pocket, and it was hanging in his locker because he didn't want anybody else to use it. So, but that's when you involve finance in that, start generating the reports, involve cybersecurity in it. With a high risk device that comes up missing and it's got PHI on it, and you tell IT, cybersecurity, that it's missing, it gets a lot of action. So understanding huddles. So use of a huddle board. So it's a visual snapshot of the current state, and it gives us an idea of where we are performing and where do we need to focus. So that scoreboard, what does it tell you? Any information on there that's helpful, useful? It doesn't tell you anything, does it? Besides, maybe the game hasn't started yet, or maybe it's already over. But there's no good information on that scoreboard. That one, what does it tell you? You can participate if you want. What's that scoreboard tell you? What's the valuable information on that scoreboard? What's that? Game's almost over. It's 37 seconds left. Who's winning? Home team by 1 point. Who's got the ball? The home team. It's 3rd and 10, and the ball's at the 35-yard line. What's that tell the defense? We've got to make a stop because we still have 2 timeouts left. So we need to make a stop. And then we need to make another one so we can get the ball back because we're down 1. So that scoreboard provides really valuable and useful information in comparison to this one. This is no different. This is a huddle board, and it is a visual representation. It hangs in the department, and it tells them, here's our goals, and here's where we're performing. I don't know if this thing's got a laser on. I can't see it for you. Does it got a laser on it or not? Yeah, okay. All right. So the goal, green magnet next to it that says we're green. We're performing where we need to on this goal. This one, not so good. We're in the red on this one. This one, we got 1 green, 2 yellow. So we look at our tactics down here and where our metrics are at, and they're written in green. That means we're performing where we need to. Same thing here with the magnets. So this is a visual representation and a visual scoreboard. Where does this data and information come from? It comes from the dashboard. So when you look at the performance dashboard, you can print out reports and you can put them onto a visual scoreboard. And we do this so that when I walk into a department, I can tell where they're performing, how they're performing, where they need to focus. It gives me a snapshot. Within 10 seconds, I can tell how that department's doing just by looking at the color coding on the huddle board. Also, our teams meet around this huddle board on a routine basis. Whether that's daily, twice a week, 3 times a week, the cadence is up to the leader and what's most effective. I meet with my team on a huddle twice a week, virtually. But we have a performance board and we have a dashboard that we can look at in that huddle. So understanding, again, a short focus meeting involving members of the team allows them to sync on progress, identify challenges, and determine priorities. It keeps the team aligned, encourages collaboration and communication. It identifies challenges, obstacles, or issues. And the best practices are huddles should not be more than 15 minutes. A huddle should be 15 minutes or less. And you focus on specific topics or areas of discussion. Utilize a structured agenda or a huddle board. The agenda piece from a virtual standpoint, that's what I use on the virtual huddles that we do. In person huddles, I go do a step back review at facilities and we use the live huddle board. The one that's in the shop, I've got a couple technician savvy guys that have theirs electronically on a video screen instead of on a whiteboard or on that. And then ensure participation by the entire team. So if there are 3 techs, ensure all 3 are participating. If there are 10, make sure they're participating. Because that's where the collaboration, communication, and the teamwork comes in. Again, it drives caregiver engagement. So make sure same time, same place. So we're not huddling in this area, then we're huddling here, then we're huddling here. If you have a huddle board, that's the best place to do the huddles. And from a leadership standpoint, it is your responsibility as a leader to ensure that they're occurring and that you are in attendance routinely, if not all the time, at that huddle. You don't have to be at every one of them, but that's where the teamwork and the collaboration and making sure that everybody is involved in the huddle process. Have them lead it. You don't need to lead it. Step back. Hey, Tech, I need you up here. I want you to lead huddle today. Again, that's where I talk about choose a huddle facilitator, and it can change for huddles. And in fact, I would recommend it changes for huddles. This one here, you can see this is one of my area directors, Scott James. This team here is a group from Denmark that came in to just visit Intermountain Healthcare, or Intermountain Health. We took the care out of healthcare, so it's now just Intermountain Health. But they came in to look at what we do and what our processes are. So the organization, the leadership of the hospital, when they came in, they said, hey, we want you to see Huddle Board and how it works and how effective it is. And the one we want you to see is in clinical engineering. That felt good because these people are not clinical engineering or HTM people. These people are clinicians, doctors, but hospital leadership said, we want you to go to clinical engineering to see the Huddle Board in action. So that's Scott presenting, and he's the one that's got the TV with all the information on it. Here, this is our central group. Priya, are you in there? No, that was after it was okay. Yeah. So this is our central group here. Anybody from Kaiser in here? You know that guy? That's Dustin Smith. Dustin used to work for me as well. Great guy. But anyways, this is one of our service coordinators. So our service coordinator, and she's the one that's running the huddle. And you can see this is our huddle board from a central standpoint. And again, you can look at it quickly and you can see green, red, yellow, and it gives you an idea where we're at. Now the items across the top are our Intermountain standards, quality, safety, caregiver engagement, stewardship, ideas, things like that, that we've got up there. So we list what we're looking at. Review the KPIs, metrics, and goals. Priya, keep me on time, will you? I can count on Priya. She did that for me for a number of years. She kept me in line and online, in line. So, but meaningful data and reports. You know, for those that go back a ways, before George Mills at Joint Commission, there was a guy named Ode Kyle, and Ode Kyle was quite the guy, and he actually left the Joint Commission and came to work for one of the facilities that I was responsible for in Illinois. And Ode was running the EOC safety committee meetings, and I went into that meeting one time and I had my report and I slid it over to Ode, and he looked at it and he said, There are actionable items on here. I said, yeah, there's 2 or 3 of them in there. Well, what's the rest of this data? Well, it's just an update where we are with PMs, where we're, you know, and he said, I don't need that data. Email it to me. It's useless. Takes up my time, valuable time in a meeting. I don't need it. Send it to me in an email. Just present to me what are actionable items and useful data. And I say that's the same thing when we're looking here. Meaningful data and reports. Can you have your PM completion percentage up here? Absolutely. Is there any reason to cover it? Not if we're on target. No reason. Jump right over it. Ideas, again, solicit the team for ideas. And this is important as well. Huddles are not for problem solving. They are to identify issues and problems, but they are not for problem solving. Because if you start getting into the problem solving, all of a sudden your huddle goes from 10 to 15 minutes to 20 to 30. Not problem solving. If there is an issue or a problem, identify it, move on. And then those that are responsible in that area, you can task to develop a return to green, or what do we need to do? Does it need to be escalated up the organization? The idea is keep track of the submissions and categorize them. To do, in progress, complete, focus on safety related, stewardship, quality, patient experience. This is an example of a huddle board agenda. So we look at things, safety stories. We'll look at things like, hey, got any safety stories to share? Any good catches, near misses? I had one manager that when we covered that, he goes, yeah, I got one. He said, you know, we were deinstalling some equipment in the hospital. I don't have my MD Expo thing on, but most of our staff on their badges, they have lanyards. And he said, I went out back to the dock and we were throwing some equipment into the dumpster. And I grabbed the equipment and I threw it and it caught my lanyard as it was going into the dumpster. Thankfully, I had a breakaway lanyard. And that's what went into the dumpster. But if I didn't, there's a potential that equipment could have pulled me into the dumpster with it. Good catch, near miss, right? So that's something we shared across the enterprise. Said, hey, listen, if you've got lanyards, make sure they're breakaway so that you don't get it caught up in a piece of equipment or anything like that. So we cover those things, announcements, miscellaneous business, items that need escalation. That's where we look at the problems. What items do we have where there's issues that need to be escalated? Review the daily focus. Look at action items and where are we at on those? And don't forget recognition. We do our recognition in our huddles. So we may say, hey, I want to recognize the guy that was on there, Scott James, my area director. I want to recognize Scott James because this month he is celebrating his 40-year anniversary with the organization. Or this person received a kudos from this department. So we share our recognition in those huddles as well. This is a huddle board example. This is Scott James. He's got the electronic one that he's got in the shop. This one is in his office. So he looks at it every day and you can see the green, the yellow. Scott rarely has any red. So he is a data guy. So, and then this is the one that was in our central office, the huddle board here. So using them together, the important thing, looking at the dashboards. So determine what are those KPIs, metrics, tools, and resources. How is it automated or can it be automated? And then align the data with the goals and objectives, not only of your department, but how does it tie into organizational? It doesn't have to tie into organizational on the performance dashboard, but you need to be able to explain it on how it ties in and how it aligns. Huddles determine the frequency. Again, Intermountain does a tiered huddle process. So we have tier 1 through tier 7. And items that may be identified in tier 1 that need escalation to tier 2, they go to the next huddle, up to the next huddle. And it's different. So tier 1 may be just the clinical engineering department. That's the tier 1 huddle, to where the staff's coming together. Tier 2 may be, it includes not only clinical engineering, but it includes facilities management, safety and security, from those groups. And then tier 3, tier 4. You get up to tier 7. The tier 7 huddle includes the organization, the health system CEO. So we may escalate things up, and we may get something like, I'll get in tier 5 and they'll say, we've got a CT scanner, or we have a CT injector at CASIA that's been down since Friday, and this is Tuesday. Why has it been down so long? What are we doing to rectify it? So then I've got to look into it. And again, the huddle process is not problem solving, but what they're saying is, we've got an issue, somebody needs to research it and look into it. So they send it to me, and then I look into it and I say, why is that injector not repaired yet? And then I find out that our guys that are doing injectors in-house, one of them said, I didn't realize we had a hospital in Idaho. Well, that's a problem. So, but Justin, he's going to take care of those going forward. So that's right. So anyways, that's, that data, though, anything that needs, there may be informational items that escalate, but there may be items that escalate that require assistance from somebody else. Or I may need the imaging director to, somebody's calling me. I may need the imaging director to intervene in something. Or I may need my imaging manager to get a hold of GE to find out why and what's the status. And then I got to report back on that until the problem is resolved. We've got a huddle escalation process. We document data in until the issue is resolved. So combining dashboards and huddles, you can see how they intertwine, that one depends upon the other. You look at data-driven discussions. You look at clear goals and accountability, increased transparency. So if you look at those items in combining the dashboard and the huddles, it'll drive performance improvement. Again, how do dashboards support the huddles? Relevant, factual information. It encourages the team discussions. It allows you to look at goal progress. Performance is visible. Tracks and trends, provides historical data. So you can look at it month to month if you want. You can look at it year to year, however you want to set that dashboard up to be able to provide data and information to you. And then it keeps assumptions out of the equation because it's factual data and information. So it's relevant, accurate, and current. So there are no assumptions at this point. And people say, well, I think our PM percentage is down that low because we're down 2 members of our staff and we're shorthanded. And then we look at it and we go, you know what? That's an assumption. If you knew that that was going to happen, now sometimes you don't, but if you knew that was going to happen, why are you not reaching out for help? Why are you not planning in the future? Why are you not getting things set the way that they need to be? So there are no assumptions. Dashboards support huddles. I would say utilize the prepare, share, and act process. So you want to make sure that the data is prepared, what needs attention, color code the items and that visual display, share the information. That's where you're looking at it from a huddle perspective. You're gathering the team together, whether that's virtual or in person. I would suggest that within the facilities that it's in person. And if it's multiple facilities, then you can do the virtual. And then drive through change. Utilize the tools and resources that are available. Talk to your DTS department. Talk to some of the others. If you've got a continuous improvement department, which we do, I talk to continuous improvement and I say, hey, the CI portal, the performance dashboard, this is what I'm looking at. This is what I'd like it to do. Can it do that? And they're more than happy to jump in and help. They're also more than happy to go out. I have had them go out to the departments and sit with the team and the staff to go through how to do it. I mean, from start to finish on how to set it up, how to do it, what's the value. Where am I on time for you? 10 minutes, okay. KPIs, watch metrics, goals, standardizations. Again, HTM goals, it provides a specific endpoint. They're clearly defined and measurable. KPIs are targets that impact strategic department outcomes. So when you look at goals and KPIs and watch metrics, are they the same? They're related, but they're not the same. So your goals are really clearly defined, measurable, and it provides a specific endpoint, where your KPIs are targeting strategic department outcomes. So it may be long-term when you're looking from a KPI perspective, and it really supports the strategy. Where the watch metrics, they're related, but they're not the same as KPIs. So when you look at your watch metrics, they measure success of department activities. Now, you may have a KPI like we did with could not locates. We had a KPI. We had a KPI that we had set that was tied to a goal. And then when we got to where we wanted to be, we didn't want to forget about it, because as soon as we do that, the numbers will start to climb again. So what we did is we moved it to a watch metric so that it was continually on the board and we could see where we were at and make sure that we're still following the workflows, processes, and procedures that we had set. So it becomes a watch metric. PM compliance, same thing. Does it need to be a goal or a KPI? No. Joint Commission or the CMS, you know, this is what they require. It's required. So it doesn't need to be a goal or a KPI, but it does need to be a watch metric. And then standardizations. You can take this data and information here, the goals, the KPIs, and the watch metrics, and you can develop standardizations off of those. And those provide rules, processes, and guidance to conformity. So when we looked at it, we got 33 hospitals out there. We have 179 FTEs. And when I first started Intermountain, they were all doing something different. And they were doing it different ways. And when somebody would bring something up, they would say, yeah, that works for you, that's great, but we're just gonna keep doing it the way we are. Or we would start to implement something, they'd say, we're gonna opt out. Well, you know what? We're standardizing. There is no opt out. Everybody will do it the same. I had medical equipment management plans that were anywhere from 2 pages to 25 pages. Well, you know what? Now we have a template that Priya put together. We have a boilerplate template that goes out, and our directors and managers customize that data and information where we tell them they can customize it, but everything else is the same. When Joint Commission walks in the door, they see our MEMP. If they go to a facility down the road, it's identical. Yes. 14 years. 14 years. No, I would say that, you know, it really involved, it wasn't just me. I wish I could take credit for it, but I can't. It is those that I brought in leadership positions and those directors that we brought in that said, this is the strategic plan, this is the goal, here's where we want to be, here's how we get there, and getting buy-in from them and them helping us make that change. Now, there were some people that said, you know what, I've got 35 years with the organization, I don't want to do that, I'm retiring. So, okay, enjoy retirement. Or some that said, you know what, I'm going to leave. Okay, good luck in your next position. But it really explaining the why behind it and how it impacts the organization and how it, more importantly, it impacts the patient, and explaining that. So it probably took, I mean, I'm not going to lie to you, I've been there 14 years. It probably took 10 years to change that culture. And it took bringing in leaders like Priya, like Dustin, to help drive that. This is an example of standardizations that we put in place. Standardizations that we do standardization initiatives every quarter. We do at least 2, sometimes 3. These are quick wins. So these are items that we put in. The organization was focused on likelihood to recommend. Likelihood to recommend the organization. Well, how do we contribute to that in clinical engineering? Well, they put an emphasis on it. We looked at it and said, you know what, we've got techs that are going into patient rooms when there's patients there. What do they say? What do they do? You know, I've always said that, you know, our clinical engineering, our techs are introverts. And, you know, the way that you can tell the difference between an introverted tech and an extroverted tech is an introverted tech looks at their shoes when they're talking to you, and an extroverted tech looks at your shoes when they're talking to you. So how do we train them? So we look at the script. We put together a script set. If you go into a patient's room, there's a patient in there or family members, this is your script. This is what you say. And it's made a huge difference. We look at ADET. You remember what it stands for? It's acknowledge, identify. I forget what the rest of them are. Anyways, the 10-5 rule, yeah. The 10-5 rule was when you're 10 feet away, you kind of make eye contact. When you're 5 feet away, you acknowledge them. So you say, hey, good morning, or good afternoon, or how you doing? Which is brand new for a lot of techs. We looked at acquisition value. We looked at our apprenticeship program. So quick wins, things that you can get done in 90 days. Identify what it is, what's the significance, what are the deliverables, and what does success look like? And can I get it done in 90 days? Now, there are some projects that you say, we're gonna break this one up into 2, and we're gonna do this in the first 90 days, and then we're gonna carry it over and do this in the second 90 days. So, and you can do that, but these are quick wins, and it involves the entire staff, from leadership to the front line.